Hello, everybody. My name is Dr. Freddie Garcia, and today we're joined by Dr. Adam Klotzek, and we're doing a webinar on the topic of transcutaneous vagal nerve stimulation. We're going to be talking a lot about that, and at the end, we're going to talk about how the Stimpod NMS460 and its application of transcutaneous pulse radio frequency can make your vagal nerve stimulation even better. So we're going to be talking about that. Before we do that, I want to tell you a little bit about Dr. Klotzek. Now, Dr. Klotzek has been very generous with sharing his expertise with us on various topics. And we're getting actually amazing reviews for it. So, Dr. Klotzek, kudos to you that everybody loves learning from you.
Well, thank you. I appreciate that.
Yeah. But if Dr. Klotzek is new to you, Dr. Klotzek is a DC, and he holds a Doctor of Chiropractic degree from Logan University, along with his neurology diplomate status. He's an accomplished worldwide lecturer in the field of neurology and neurological treatment, delivering over 700 presentations, totaling over 11,000 hours of education on various topics. He has over 25 years of clinical experience in the trenches, and he's attended to over 12,000 patients, treating them for a multitude of neurological and non-neurological conditions, including but not limited to things like concussions, vestibular disorders, chronic and acute pain conditions, headaches, ADHD, neurodevelopmental disorders, scoliosis, sports related injuries, and more. He has a special interest in developing novel treatment applications, uh, an interest in the effects of joint misalignments and manipulation on brain function. And he's also authored a number of published research papers. When he's not busy studying, learning, and being a clinical consultant, he loves music, playing the guitar, fine dining, fine wine, reading, personal development, and spending times with his close friends and colleagues, which I'm lucky to say I'm one of those people. So I feel fortunate too. Thank you and welcome to another webinar, Dr. Klotzek.
All right. Thank you, Dr. Garcia, for that gracious introduction. And I'd like to also thank Algemed for giving me the opportunity to share information about vagal nerve stimulation. As a lot of you know, vagal nerve stimulation is like the in vogue thing to be doing with patients with a whole bunch of different conditions. So,
With good reason, which I think you're going to
yeah,
share that with us.
yeah,
Dr. Klotzek, before you
basically
get
it
started,
works.
before you get started, I'm going to jump off the stage. I can tell you're ready and rearing to
Oh,
go.
okay.
I'm going to jump off the digital stage. I may come back if I have a pressing question or if somebody has
Yeah.
something really pressing in the webinar chat, and then I'll be back at the end to do a little outro with you and do some Q&A if there are any questions. So the digital stage will be yours, and I'll see you on the other side of it.
All right. Thank you. All right. So yeah, we're going to spend some time talking about vagal nerve stimulation. Obviously, not the invasive kinds, where people, doctors go in there and they wrap these coils around the vagus nerve. That's not really within our scope. So we're going to talk about the non-invasive kinds, and more importantly, we're going to talk about transcutaneous vagal nerve stimulation. Um, for those of you who don't really know me that well, I'm kind of a why guy. I've always been intrigued as to the why of how things work. Why does this happen? Why do you get results when you do this, etc.? And I've always thought that if you could answer the why, you could automatically develop the how, or how to change things if things aren't working the way you want them to work. So we're going to spend some time in the next half hour or so going over the why of transcutaneous vagal nerve stimulation. But at the same time, we're also going to talk about the different technologies that have been used, that have been studied. And we're also going to talk about why one technology may be better over the other, etc., and so on. So just to give you a lay of the land, we're definitely going to talk about some neuroplasticity concepts, talk about the history of neuromodulation, pertinent clinical anatomy of the vagus nerve. We won't go into a lot of detail with that. We just don't have enough time. But then we're going to be spending more time talking about the mechanisms of action. How does this actually work? Why are clinicians seeing the results that they're seeing with vagal nerve stimulation? But more importantly, why the pulse radio frequency? That is something that really intrigued me from hearing from various doctors with the results that they're getting with pulse radio frequency. So we'll be obviously emphasizing that. What conditions can you treat, or what has been out there in the literature? How do you stimulate the vagus nerve? Is there a difference between sites? Which one is better? Which one is worse? Obviously, contraindications. What are some treatment parameters? And then again, spotlighting the difference between DC galvanic, which is one of the stimulators types, and then pulse radio frequency. And then hopefully we'll summarize things, and everybody will hopefully enjoy the information that they learned. So let's just start off with neuroplasticity. So, neuroplasticity is also the in vogue thing. I mean, people are talking about the brain these days and how we can change the brain, make it work better. There's uh, techniques that are out there that are, brain centric or focusing on making changes in the brain. And vagal nerve stimulation plays a role in that. So, neuroplasticity, what I do want you to understand, it consists of two main concepts or ideas. The one is neuromodulation, and I'm putting parentheses here, DC galvanic, because one of the ways that you stimulate the vagus nerve is using a DC current. And it has been shown that the DC galvanic seems to focus more on the neuromodulatory effects for nerves, meaning that it's more of a functional change that happens in the nerve. You can either make the nerve work better, long term potentiation, make the nerve work worse, but really just involves, delivering an electrical stimulus and over the nerve, as well as, using pharmaceutical agents, which is not really part of what we do. So we're not going to talk about that at all. But I want you to understand that in order to neuromodulate a nerve, you need energy. The nerve needs energy. The nerve needs ATP. It needs to produce more transmitters, vesicles, etc. And that's going to become really important when we start distinguishing between the two types of main stems, the DC galvanics and the pulse radio frequencies, which are more involved in the neural remodeling part of neuroplasticity. And this is really important. These are the actual structural changes that happen within the axon, the synapses, you make more synapses, the neurons, you make more axons, the myelin sheets get thicker, you get more mitochondria in the cell bodies. And these are actual structural changes, obviously influencing function as well. But this also requires energy. Um, and it requires ATP, et cetera. And again, I'm pointing that out to you because it's going to become important in a little bit later in this presentation. Um, what has been developed as a result of these electrical stimulators? Well, you get cardiac pacemakers, spinal cord stimulation, transmagnetic brain stimulation. They all work on the same basic principle. So let's just talk a little bit of the history of neuromodulation. I just found this interesting when I was putting this seminar together and going through the literature. I do want to let you know that there's probably about, I say, 40 plus articles, contemporary articles that are supporting what we're talking about here. So it's taken me a little bit of time to put that together for everybody, but I think it's well worthwhile. So let's just start in the beginning. So in the beginning, like the Egyptians, if you look at their tombs, there are hieroglyphics on the tombs of these pharaohs that basically are drawings of catfish. And what's interesting is that the Nile electric catfish, obviously electric, produced electricity. So, why were they actually spotlighting that in the tombs of these pharaohs? Well, we also have accounts where back in the Greek days, etc., that they would use, torpedoes, which are basically electric rays, and they can produce voltages of up to 225 volts. And they were using these rays to treat themselves of various painful conditions. There's one story where one guy was walking on the beach, and presumably he had gout, and he stepped on one of these torpedoes, obviously got shocked to crap, and his gout got cured. He didn't have any more pain in his foot. So you can look at these rays as being the first portable electrical stimulators. Um, so there's a lot of references to them historically, but it just gives us the idea that hey, electricity or radio frequencies waves and all this other stuff does affect our bodies. Well, then Galvani came around and he basically discovered that the nerves or our nerves work based off of electricity. Then we had the development of the battery, and then we had circuits, electromagnetic induction, and eventually we had the first electrical therapy device. So then, because of all these inventions, we got our pacemakers, we got our implantable devices developed. But also during that time period, there was another, lineage of literature or experiments being done, and this was using a different frequency range. And the first accounts of like radio frequency use was way back in the 70s. I'll talk a little bit more about that. But then it developed into using pulse radio frequencies of later on. And then, we had the development of the inflammatory reflex, and that was like a game changer because the discovery of the inflammatory reflex, now everyone goes, oh, this is why these devices work. And that started a whole string of things. And then eventually we got into, vagal nerve stimulation later on. And then at the end, we eventually got into what's called transcutaneous pulse radio frequency stimulation as a therapy, etc. So we'll expand on that a little bit more. Um, but the summary events were this. In order for us to have had developed all these, like this idea of electricity and the use of electricity, etc., to treat people, we had to dismiss something. And we had to dismiss, Descartes' idea of the nervous system. Now, this guy, he thought that nerves worked as plungers, and basically you'd have fluid in these nerves, and basically you'd have a plunger that would physically move the fluid in the nerve to cause the limbs to move. Well, that didn't go over very well later on, so they finally dismissed that. And then we had Galvani come around, and he basically found that you know if you complete a circuit, by having a rod touch two different metals, you can make a frog's leg basically contract. Now, this copper coil is attached to the actual nerve. So you got copper coil here, you got, the connecting rod, touch them, and the frog's legs moves. Then we had the battery discovered and all this other stuff. So all this stuff led to the development of these devices. And we already talked about what kind of devices they are. But let's talk about another arena here, and this is the use of another frequency or higher frequency range in the 500 kilohertz areas. Um, and let's look at the historical development there because I think it's very important, as you'll see here as I go through this. So the first accounts of radio frequency use was back in the early 70s, where researchers discovered that if they expose the nerve to a 500 kilohertz um, waveform, that it would cause thermocoagulation. And that started the whole idea of radio frequency ablation for the treatment of different conditions. But then in the 80s, which was interesting, they discovered that the application of constant radio frequency ablation to distant nerves also yielded positive results in the area that was involved, like in pain or something along those lines. So this was interesting. I'm trying to figure out why the application of a coagulating thermal stimulus that damages the nerve improves a condition that is not related to that particular nerve or level. So that's kind of started the conversation about this whole idea about immunomodulation. So these the radio frequency waves doing something a little bit more than what they thought just with regards to thermal coagulation. Well, then in the 90s, researchers proposed, well, why don't we try to see if we pulse this? And it's not going to be constant. We're just going to pulse the radio frequency wave. So they refer to that as pulse radio frequency. So you have an on and off. And what they found is that it was a good alternative to constant radio frequency ablation. But with pulsation, you don't cause damage. So they're thinking like, all right, why is this working? Well, that in 2008, they found that intra-articular PRF was also very effective. See, before they thought that you actually had to touch the nerve. The actual probe had to be on the nerve to create the effect. Well, they found later on that you didn't have to do that. So now they're thinking, okay, what is really going on here? What are things doing? And get a load of this in 2013. This is really cool. They started doing intravenous pulse radio frequencies using the cephalic vein, which then had positive systemic effects. These guys were treating, there's one account of a physician with lung cancer that went into remission. There's accounts of people with depression and other types of disorders doing well with this type of therapy. So the thing I want you to get here is that pulse radio frequency treatments has a systemic effect on function within your body, not only nerves, but other structures. So to me, that's really intriguing. And to me, from a clinical standpoint, it suggests a very powerful positive effect that we could leverage. So in 2015, eventually they discovered that they didn't have to actually, cut the vein and stick the probe into the vein itself or into touching the blood. They found that pulse radio frequencies waves easily cross over the wall of an artery or vein, and that led to development of transcutaneous techniques, which is kind of what we're seeing right now and kind of what you're seeing with the Stimpod. But it was very interesting progression how they got to that. So we do need to talk a little bit about the vagus nerve. The important things here are is this: 80% of the fibers in the vagus nerve are afferents. Only 20% are efferents or efferents, meaning that the majority of what you're doing when you're stimulating the vagus nerve is that the information is going central. And where does it go to? Well, it goes to one big area, and it's called the nucleus tractus solitarius, or what people refer to as the NTS. Now, that area is really important because what the NTS does is it fires to other central brainstem structures, one being the locus coeruleus, which is depicted here, and another one not depicted is the nucleus raphe magnus. So the locus coeruleus is involved with noradrenaline, noradrenergic integration, and the nucleus raphe system is involved with serotonergic. But just look at this. Look at the output of the locus coeruleus. And I think this will start to shed light as to why vagal nerve stimulation has far-reaching effects outside of where you're stimulating. You're going to affect the cerebellum. That's movement. Amygdala. Hey, emotions, right? Wakefulness, attention, prefrontal cortex, behavioral stuff, anxiety, depression, sensory processing. So you have a wide gamut of areas that are going to be influenced by output from the locus coeruleus, driven by output of the NTS, which is then driven by vagal nerve stimulation. Super, super cool, and really sheds light as to why we see the things that we're seeing. And remember, I'm a why guy, so I think it's important to understand that. Now, the locus coeruleus just doesn't project to the brain, but it also projects down into the spinal cord. Oh, motor control, sensory function, pain control. We'll talk about that. So interesting. Now, you do have efferent fibers. I'm not dismissing these fibers. And they originate from the nucleus ambiguous and the dorsal mononucleus of 10, and they project to cardiac, respiratory, and visceral organs. So you're going to have an effect directly on those organs, but understand that you're also going to have a significant effect on other systems due to these central projections. So let's look at the therapeutic goals. What are we really trying to do with vagal nerve stimulation? I think I've hinted to some of these things, but basically, you're really trying to create inflammatory homeostasis. If you think about it, you could kind of relate that inflammation is the root of all diseases, which is not too far out there. because of what we're seeing in the literature. But basically, you want to restore balance. And the balance is that when inflammation gets out of control, the output of your dorsal motor nucleus of 10 or your vagal centers can't control it. So stimulating the vagus nerve has the ability to restore balance using more of a non-local neuroinflammatory mediating process. Now, a lot of this stuff was discovered by studies done with sepsis. So basically, they discovered, and a good article review is uh, Rosas and Bellina in 2009. And they discovered that brain signals via the vagus nerve reduce inflammatory cytokine production and improve the survival in sepsis models. So that led to this whole idea of vagal nerve stimulation creating inflammatory homeostasis. Then you really can't talk about vagal nerve stimulation unless you talk about the cholinergic anti-inflammatory reflex. And what that is basically immune cells are going to produce cytokines. They're going to stimulate the afferent fibers of your vagus nerve into the central autonomic um, networks. You're going to have an output that then causes an increase amount of acetylcholine, and that acetylcholine stops the cytokines. So if you just look at this in a very simplistic manner, I mean, if you have a problem with this output, you're not going to be able to mitigate and control inflammation. And that is part of the why behind vagal nerve stimulation. It's a very good way to increase the output of these fiber systems to mitigate inflammation. Now, we also have the benefit of neuroimmunomodulation. So not only do we achieve this through the cholinergic anti-inflammatory pathways, but you got the hypothalamic pituitary axis and you got the splenic sympathetic anti-inflammatory pathways. You got three systems all working together, driven by the integration of the NTS, the stability of the NTS to help modulate inflammation, which we all know is normal. I mean, we need inflammation in our body, we need it to heal, etc. It becomes a problem when it gets chronic, which is what we're seeing, a significant increase in our society. And we could have another discussion as to why that's occurring in another day. But here, get a load of this one. These cholinergic fibers that are being stimulated from your brainstem also go into the spinal cord. They go right into the dorsal horn. And what they do there is that they block the primary and second order neurons associated with pain fibers. They already know that with nerve injury, in neuropathy, and in neuropathic pain, that the cholinergic tone is decreased. You just don't have these fiber systems working as well. And basically, they have found that if you simply increase the amount of acetylcholine being released, the cholinergic tone, it induces analgesia. So now you got vagal nerve stimulation as a adjunct to treating different pain conditions, which we'll talk about. So it has I'm just amazed at the wide usage that this one little type of therapy can impact on a person. And, and it's a good tool to have. So what are the treatable conditions? Well, we'll just run through these. POTS, believe it or not, vagal nerve stimulation improves POTS. It improves mood. A lot of people with POTS are depressed. At least most of them are, and most of them are anxious. So how does it work? Well, we already talked about how it works. You can vagal nerve stimulation. You're going to activate, your locus coeruleus pathways, changing brain activity, prefrontal activity, reduces sympathetic pacemaker activity in the brainstem. So your rostral ventral medulla is a key center for you to remember. This guy right here activate your sympathetic system. It's part of the pressor responses, etc., vestibular activation, but it's regulated, and it's regulated by the caudal part of the ventrolateral medulla. So it's kind of like, the underdog, slapping the person up on top of them and putting them back into place. Well, how does it work with vagal nerve? Well, this is the auricular aspect that you could use. Well, you're going to stimulate the caudal ventrolateral medulla, inhibit the rostral ventral, and you're going to decrease your heart rates. And then we have the vagal outputs, through the celiac ganglion to the spleen to reduce cytokine production. So that's pretty cool. Post-stroke rehab, right? Here's what they found, that with vagal nerve stimulation, you have a neuroprotective effect on the nerves. You have the promotion of angiogenesis. So these areas get damaged. You can produce more vascularity around the areas damaged. It protects the integrity of the blood-brain barrier, I'm sorry. And it also reduces cortical spreading depression. Now, for those of you who may not know what that is, it's a process where the neuronal activity in the brain gets depressed. So it slows down, but it spreads over non-vascular territories. In other words, it's just not confined to the distribution of the middle cerebral, posterior cerebral arteries. So the mechanism, a little bit complex, but it doesn't involve actual vascular integration. It's another mechanism, but it's good because cortical spreading depression has been implicated in primary headaches, been implicated in migraines. So it's pretty cool. You can decrease that. So yeah, primary headaches and migraines. So here we go. Here is vagal nerve stimulation. You're going to modulate down through here. So you're going to decrease the activation of the trigeminal nucleus, which is important. Also, you're going to modulate autonomic function. Here's your trigeminal neurons again. Cortical spreading depression, nociceptive modulation. So it's something that, if you have headache patients and you're treating headache patients, for me personally, it makes sense to perhaps incorporate vagal nerve stimulation as part of your repertoire. And it's not going to hurt them, as we'll talk about. There's very little downside to it, but there's a lot of upside potential. Low back pain. So here's what they did. They did this study, and this was done by Halim in 2023, so fairly recently. And they had a control group where they just gave them exercises, which a lot of us do. And then they had the intervention group, and they got exercise and vagal nerve stimulation. So these were the parameters that they used. They used 25 hertz, a pulse width of this. Intensity was the patient's tolerance, and they gave this to them 20 minutes a day, 20 minutes 5 times a week for 2 weeks. Okay, on top of doing their exercises. So one group just did the exercises, one group did the VNS and exercises, and what they found out, well, hey, the people who got the VNS with the exercises did a heck of a lot better, significantly better, with p-values of 0.001. Those are good. Those are really, really good p-values. So they had some ideas of how this all worked, but basically we've already talked about it. It's the anti-inflammatory, cholinergic activation, the effects in the spinal cord on these pain fibers, etc. Epilepsy. This is kind of cool. So it has been known for over 30 years that vagal nerve stimulation helps with epilepsy. So it's been around for a long time. And what this study did, 2021, what they did is that they looked at the cortical networks that were involved in epilepsy. And what they did is they measured their activity prior to the stimulation, which represents this right here. And then what they did a stimulation. This is 1 hour here, 1 hour there. And what they found is that during the stimulation, the network stabilized significantly. So this instability that is thought to contribute to the epileptic attacks, etc., became stabilized during the stimulation. Now, when they took away the stimulation, we started to see a return to normal. But in 30 to 50% of the subjects, though, the effect persisted for an extended period of time. So, again, vagal nerve stimulation, stabilizing brain networks, etc. Cardiovascular disease. Now, the studies that have been done on this have mostly used low level transauricular, so in the ear types of stimulation protocols. And they basically used an intensity. This is important for the cardiovascular side of stuff. So if you're thinking about treating like increased heart rates and arrhythmias and stuff like that, you're going to want to look into this. So what they do is they use probably around 50 to 80% of the stimulus strength. That reduces the heart rate. So what you do is you ramp up your device until you notice the heart rate decreasing. You do it a couple ways. You could use your stethoscope, listen to the heart, or you could use a pulse oximeter. I think it's probably more accurate to use a stethoscope. The reason why is that these pulse oximeters have a delay between the actual measurement and the time that they display it. Not a big delay, but in a pinch, you could just use your stethoscope. So what are the treatment benefits? Well, it suppresses AFib. That's cool. Alleviates post-MI, whatchamacallit, downsides in the heart. So ventricular arrhythmias, ischemic reperfusion injuries, it helps with that. It also improves diastolic parameters in heart failure. And these are particular ones that have not impaired left ventricular ejection coefficients. The mechanism is thought, just like we've been talking about, restoring favorable sympathetic vagal balance. COVID-19. There's studies out there that have shown that vagal nerve stimulation can benefit COVID-19 patients. And there's significant stuff out there with regards to the respiratory effects and the ability of vagal nerve stimulation to help those. So it protects against infection, attenuates acute lung injury, improves lung function. Other effects, for the COVID-19 is, the chronic inflammation that is the suspect that produces a lot of the long-term effects, but vagal nerve stimulation helps with that. So, kind of put this in here for you. It just kind of reiterates the same thing. Here's COVID-19. You're going to have an immune response to that. You're going to dump a lot of cytokines into the system, and you're going to try to modulate that down. So, in a great functioning system, you might be able to modulate it down. But the majority of us don't have good function here. I mean, these areas are not that viable. They're not that integrated. Uh, they don't. Their output can be significantly compromised. And then we see the output of the DMV here producing its changes with regards to cholinergic and the suppression of inflammatory mediators. So, with all that said, I think you get the idea of how vagal nerve stimulation works. I think you understand a little bit of a difference between the galvanic portions or the galvanic stimulators that are out there and their neuromodulatory effect, and the systemic and neuroremodeling effects of the use of pulse radio frequency. So we're going to focus in a little bit more on that. So what are the stimulation sites? Well, you got two. Why do you have two? Because that's where the vagus nerve goes. So you got the auricular areas, you got your Simba and Concha, you got the tragus. Then you got your cervical area, and this is usually over the SCM. It's probably like around this area up and through here. Um, Now the question is, which is the best site? That is like the ongoing, well, do I do a cervical? Do I do an auricular? And I will allude to this, but Currently, the general thought is that the auricular seems to be the better choice. Why? Just because of the fact it's easier to find the stim point. I mean, pretty well anybody can find the sympaconcha. I mean, unless you're blind, I guess it'd be hard to find, but you can see it. You pretty well put a probe on there and stimulate this area, as shown here. There's a Stimpod probe going right on this area, right in through here. Now the question becomes between these areas, I mean, which is the best one? And that's difficult to answer because there's different research studies have used different protocols. Some have used the tragus, some have used the concha, some have used the Simba concha as their primary standpoint. So my recommendation to you, they all have a chance of working. Okay. If you find that the Simba concha is not working for your patient, maybe try the tragus. Be open to the fact that you can go between these different areas, etc. And the idea is here is that everyone's probably going to be a little bit different. So let's look at the actual stimulators themselves. So you got pretty well two technologies in these stimulators. The one technology is the interrupted DC galvanics, and then the other technology out there, which is shown by and utilized by Stimpod, is the pulse radio frequency plus the interrupted DC galvanic. As far as I know, there are no commercially available pulse radio frequency stimulators that are transcutaneous. And I may be wrong on that. I couldn't find them. So if anybody knows of some, etc., please let me know. So what are the contraindications? Vagal hypersensitivity. So if your vagus nerve is already kicking in and you're hypersensitive, probably not a good idea to stimulate it. Hemophilia, psoriasis, any pimples or stuff over the stimulation site, that's pretty obvious. And any inactive implantable devices like pacemakers, even though you're not stimulating right over the pacemaker, you're still stimulating a distance or away from it. The idea is that the radio frequency waves mean they're systemic. They travel. They basically travel through your blood, to reach other areas. You're also stimulating the vagus nerve. That's going to impact the output of the SA node, so on and so on. So you want to be careful about it, and it may not be worth diving into that side of it. What are the adverse effects? First off, when you look at this, oh my gosh, a lot of adverse. Understand these are super, super, super rare. We're talking like 1% maybe on the high end, etc. So the biggest ones would be, sight discomfort. You might activate Arnold's nerve cough reflex, which is just stimulation of the ear, causes you to cough. So that might get augmented. Bradycardia, your gag reflex, lacrimation, paresthesia, syncope, vasovagal reflex, augmentation, maybe some dizziness. So, just be aware that these things can happen when you do vagus nerve stimulation. You may want to just kind of warn your patient. Say, hey, you know what? Let me know if you get a little dizzy. Let me know if you get some tearing in your eyes. Let me know if you notice any sensory stuff, and so on. Not to scare them or anything like that, but just to, so that might be happening with them. So let's just talk about the interrupted DC galvanic first. So its biggest contribution is the neural modulation. Okay, it's the functional aspect or changes. Here are the main stimulation parameters that I could pick up on. Usually the session times run between 8 to 15 minutes. What I like to recommend is that you as a clinician, if you want to kind of find out what the actual stimulation time should be, just my opinion, is you may want to pick up some biomarkers, like changes in heart rate increases. If the pupil dilates on the side that you're stimulating, probably not indicative of good parasympathetic output. So maybe the system is failing. Remember, all these stimulations require energy to for the nerve to be able to take in that stimulation. So if you're stimulating and you have a nerve, you have a neuropathy, you have something that's damaged the nerve, or the nuclei in the brain stem are just not stable, what's going to happen is that you're going to see a failure of activity. So now you're stimulating, but the nerve just says, "Hey, I'm done." Analogy would be, hey, asking your 75-year-old grandmother, you know, to go run a marathon of like 2 miles, a short one, right? Real short. She's probably not going to be able to do it. She doesn't have the metabolic capacity to do it. So be wary of that, and be wary of why radio frequency or pulse radio frequency is a superior way to address that, which I'm going to just get to in just a second. So the intensities, for cardiac, uh, most of the studies are looking at 50 to 80% below the threshold that lowers the heart rate. So I would suggest that you also incorporate that. For all other conditions, usually the patient tolerance. Frequency, this is kind of all over the place, and there's no real consistency. But what I've been able to find, usually the 10 hertz range seems to be the best at reducing heart rate. And there is one study that used a 30 hertz range that basically reduced sympathetic activity to muscles. Your Stimpod, I know, does the 10 hertz, so you should be in good shape for that, and so on. So now, hey, let's talk about transcutaneous pulse radio frequency. Why we're all here, right? Um, so with your stem pods, it combines both. So you get the benefits of galvanic, plus you get the real cool benefits of pulse rate. And here are the benefits that you get with this, but not with the galvanic. You get neural remodeling, you get structural changes in the axons, you get more of them, more myelinization, etc. You get systemic effects. So not just over the area that you stimulate, but throughout the entire body, as these RF waves travel through your blood, which is really cool. So you might be treating someone for you know, a headache, and they're going to come back and say, you know what, my low back pain's feeling better now. Oh, that was cool. Or I'm not having as much gut issues as I used to have by doing it. So those are the types of things you should be looking out for. Now, here's the other thing. I've been talking about energy. When you stimulate a nerve, you need to have that nerve metabolize the stimulus. Sick nerves don't metabolize very well. So the problem with a lot of this stimulation is if you don't have the support metabolically, you get into trouble. So what is beautiful about the pulse radio frequencies types of stimulations is that they energize nerves and other tissue. And for the nerves, it's primarily by a really cool mechanism. When you use pulse radio frequency, it activates M2 macrophages to donate their mitochondria. They literally, it's like a gift that they give neurons. They donate these mitochondria of their own to neurons so that now they can have the energy capacity that they need to produce all this stuff. I mean, you got to produce protein, you got to produce myelin, and all that takes energy. So I think that's one of the most distinguishing parts of the use of pulse radio frequency that other types of nerve stimulators just can't even touch. Obviously, this all promotes neural remodeling, right? We talked about that. Promotes neural immunomodulation. Pulse radio frequency also promotes bone and cartilage growth. And it also promotes wound healing in diabetic neuropathy. So, one of the things in diabetic neuropathy is that's a metabolic disorder. You got a sugar issue. Now, if it's a metabolic disorder and you're trying to stimulate the nerve, but the nerve can't metabolize the stimulation, you're in a conundrum. Hence why a lot of the treatments that are done for these diabetic neuropathic patients don't do so well. I'm not saying that they don't work. I'm not saying that at all, but I'm saying you could really up your game by incorporating pulse radio frequency into your regime. And I'm just giving you the why of how it works, so that it would make more sense to you and maybe encourage you more to actually incorporate this technology. So, what are your take home points? So, transcutaneous vagal nerve stimulation using the Stimpod. You got DC galvanic, induces the neuromodulatory effect, and you got your pulse radio frequencies inducing systemic and neural remodeling. Ultimately, there's no direct comparison between auricular VNS and cervically applied VNS that exists. And again, as I mentioned, there's some reports that suggest that auricular vagal nerve stimulation may be preferred just because most people can't screw up the location. A little bit harder finding the vagus nerve in the neck. And then you got other stuff here. You got muscles here. And when you're using galvanics, you're actually creating a contraction. Now, whenever you create a muscle contraction, you're going to activate the sympathetic system. Now, the biggest, how would I say this, challenge in the literature right now is to figure this stuff out. What are the treatment times? What are the intensities? What's the best frequencies? And what are the best pulse widths for the galvanic portion? Because a lot of the research is based off of these galvanics. So my opinion is based on the complementary mechanisms of both these, the DC galvanic and the pulse radio frequency, combining the two just makes sense to me. And it's really just a no-brainer. And I think that's what we're seeing, with feedback from the community of clinicians that are using Stimpods and using this technology, that they're seeing some miraculous results. Now, one last thing before I end. Another big question. Where do you place the grounding electrode when you're doing this? When you're doing vagal nerve stimulation, especially using the Stimpod. So you got your actual needle wand. Where do you put the grounding electrode? Well, here's the idea. With the grounding electrode, you don't want it too close to the point of stimulation. There's some suggestions that maybe placing it over the stellate ganglion would be of benefit, because the tissue underneath the grounding electrode, especially if it's neural tissue, will be inhibited. You may not want to put it over the carotid bodies, etc., because you don't want to really inhibit them. So you may just put it over the stellate or, on the trap. Next question is, do you put it on the same side or the opposite side? And interesting enough, the studies that I mentioned to you with regards to the intravenous use of pulse radio frequency, they placed the grounding pad on the contralateral side of the body. Because what they were trying to do here is, I think what they were trying to do is get the pulse radio frequency waves to spread out throughout the entire body and go to the opposite side. Okay. They did not, if you read the articles, they did talk about that a little bit, but it was, more from, hey, this is what we think type of standpoint. So, yeah, opposite side will work, as well as the same side. And at least for the vagal nerve stimulation, I would probably focus on the stellate ganglion. Okay. All righty. So, hey, thanks everyone. I hope that you found the information in today's webinar valuable, and maybe has opened your eyes to maybe incorporating vagal nerve stimulation into your office. Also, for those of you who are already incorporating vagal nerve stimulation, to seriously consider using a device that also incorporates pulse radio frequency. It's just what it does and how it does it is seriously amazing. I've been at this for a lot of years, and I do a lot of reading, as Dr. Garcia will tell you. So, just for this one, 40 articles I went through to gather all this information to summarize it for you. So, a lot of good stuff out there, a lot of good progress, a lot more research happening. So, thank you.
Excellent job, Dr. Klotzek. I mean, literally, I loved that presentation, and you could see that you took a lot of time to go through it. I know that some people may want some references, so you see Dr. Klotzek's email address up there. If you have questions or want some of the references, uh, email him, and he'll share with you. Um, that was wonderful. There was one question somebody asked: do you think vagal nerve stimulation can help with multiple sclerosis (MS)? What do you think? I have some
Yeah,
thoughts on that.
absolutely. Absolutely.
Yeah.
One of the consequences of MS is inflammation and neural immunodysregulation. So yeah, anything that you can do to help reduce inflammation and promote a better neuroimmunal balance is sure to help. If you just look at it from a pain standpoint, just use vagal nerve stimulation to activate those descending cholinergic fibers that come from your brain stem. Yeah, you'll help them. On the side of pain, nerve regeneration. You got MS attacking myelin, right? So you need to kick in your myelin production. Well, as I mentioned before, when nerves are sick, they're not as metabolically capable. So the vagal nerve, especially if you're doing using pulse radio frequency, is going to energize those nerves so that they have the metabolic capacity to produce the myelin that the immune system is eating away at. So yeah, it'd be very beneficial.
Yeah. You guys, it's my sentiment exactly. So awesome. Great question. To everybody, watch the seminar. Sorry that we went over a little bit on time, but
Oh, I'm sorry.
Dr. Klotzek had a lot to share. So thank you very much for your time today. Dr. Klotzek was amazing. Would you